Good afternoon, everyone. Welcome to the last webinar of the 8 webinar series of from iBank Association of India. Today we have with us Dr. Manisha Acharya. Dr. Manisha Acharya is the Director for the iBanking Services and Cornea Services at the SCEH network. She is a practicing ophthalmologist, and her passion and contribution to Indian iBanking has brought her laurels both nationally and internationally. She is the proud recipient of BMJ South Asia Healthcare Award 2016 as Quality Team of the Year for improvement in iBank tissue utilization through quality assurance initiatives, and has several publications to her credit. Welcome, ma'am, and over to you.
Thank you very much for the very kind introduction. Are my slides visible and am I audible?
Yes, ma'am.
Okay. So I thank iBank Association of India for giving me this opportunity to present and share my thoughts in front of all the very august attendees today. What we have done a little last year, it's just like, I would say, a continuation of what we were deciding, that a lot of you had attended last year's iBank Association of India meeting, wherein we did the Eye Recovery Technician Certification Program. So in this program, actually, what we did is, it's not moving ahead. I really don't know. It's not.
Ma'am,
okay.
yeah.
So if you look at the previous program highlight, what we did last time was actually the first eye recovery technician certification, which was done by iBank Association of India. And I'm very thankful to them for giving us this opportunity to conduct it there at Varanasi. There was what we did at that time also was this pre-assessment training. And one of the training was also like a webinar, what we are having today. And then there was this successful certification, which we did. And these are some of the glimpses of the training which happened last time. A total of 22 candidates attended this training, and the pass percentage was 73%. So it is nice that we all understand what we are talking about before actually trying to just participate in the certification course. So there is certain minimum criteria after which only the passing certificate will be given. And this is the team, and I'm very thankful to the entire team and those who actually bestowed their trust on us so that we could take it out very efficiently. And all the trainers who were there on that day, and especially Ganesh and Rakhi, who were a very integral part of this training. Before I go ahead of how we do the training, a little bit about how are we going to assess the trainees. So the assessment will be by a rubric, which is already a published rubric, like a REAPER, which we call very in a short form, that's the rubric for assessment of iBank professionals for eye retrieval. And it is based actually on the International Council for Ophthalmology, which is we call as, this is the Oscar pattern, which is used for assessing trainees. And it's an important proven educational tool. And if there are ophthalmologists in the attendees, they would understand a lot of the trainings of cataract surgery are done through this model. It can be used on site or in a simulated wet lab scenario. What we are doing right now would be a wet lab scenario. And there are 20 steps of the in situ corneoscleral retrieval technique, which can be objectively assessed as well as scored. So who would participate in these trainings? They would be the eye recovery technicians from the member eye banks of the iBank Association of India. So interested technicians will register for the certification at the EBI conference through a Google link, which the EBI will provide, and 5 assessment stations will be there. Past assessees would get a certification, and then if you fail an assessment, you would get a wet lab training, and then you can learn from there on and maybe participate in the next forthcoming conference anywhere in your zone, or maybe the iBank, the national conference. So we have to understand actually what we mean by a standardized in situ CSM excision. So in short, it is a standardized procedure for aseptic excision of the corneoscleral button while maintaining corneal integrity and minimizing endothelial cell loss. Just a small point. So there are three things which are there. That is asepsis, which has to be monitored, maintain corneal integrity, and minimize the endothelial cell loss. So these are the three primary objectives of a good in situ CSM excision. And if we standardize the process, we can minimize all the losses which come in the form of endothelial cell. So the steps, we say there are 20 steps. It starts from you need to wear a cap or a mask, scrubbing, and how to scrub. Sorry. Gowning and gloving, putting normal saline or distilled water on the eye, putting betadine drops, and keeping it for 2 to 3 minutes. Cleaning of the periocular area. And then putting a sterile sheet or a drape, opening the lids using sterile buds and inserting the wire speculum. Peritomy of the conjunctiva, which is 360-degree conjunctival separation, which would be done using the conjunctival scissors and adhesion separation with blunt dissection. The scleral scraping, that is outwardly from the limbus, you remove all the conjunctival tissue which may have left adhered even after removing the conjunctiva. Marking the incision with a corneal tripwire, which has to be 2 to 4 millimeters from the limbus. Then entering it with a 11 number blade, and then at the site of the groove which has been made by the tripwire, and then you're going to move around with the corneal scissors 360 degrees without perforating the choroid. And after complete corneal removal has to be done using a fixation forceps to hold the sclera where it remains stationary, and the iris forceps, which is gently going to push the ciliary body and the choroid down away from the CSM. And this 14 number step is the step which we all realize is one of the most difficult steps when it comes to the excision process. Whenever we are doing it, we call it as if you gently push down that. But we should not pull or have any pull on the cornea, because that will cause DM folds as well as loss of endothelial cells. You're not supposed to touch the endothelium at any step during the dissection. Inspect the cornea after the excision. If there is any residual iris or debris, it has to be removed before it is put back into the MK media. Whenever you're doing it, place the CSM in the storage media and maintain its endothelial side, which you think should be best over there. They transfer it there. The last step would be to check the lens status and then insert the cornea cap. And then you're going to put, these are the main 20 steps which are there. And after that, obviously, you're going to clean the work area, first close the eyelids, then remove the drape, clean the work area, place both the storage medium vial as well as the excise button in a bag, then discard all the clothes and the respective bags and rewrap instruments for transfer. So if you look at the exact steps which come for the recovery process, there are 20 steps. That is, definitely you are supposed to do it, but they may not be an immediate part of the standard retrieval process for CSM. So this is actually the Reaper sheet which is there, which gives us the brief of each step. I'm going to touch upon each of these steps as I go along. So the first step is the surgical hand asepsis. And what we have done is we have divided it into a novice, a beginner, and a competent. So if the person is a novice, then how do we define a novice? Novice is a person who's just started something. Beginner knows that, but may not be the most proficient. And definitely the last one, which we say is actually the competent person who's able to do all the steps in all of them. So we're not going to say you may be the competent in certain steps and may be a beginner in the other. So the assessment is very, very step specific as well, so that we cannot just say that you don't know this process, and that should not be the end. It should always be which step do we need to improvise so that we become competent. So the first step being hand asepsis, wherein a new person may just have the steps, they know the steps, which is followed usually by instructions, and more than 2 steps, the hand asepsis has 5 steps. If more than 2 steps are missed, then we call that, then you may just come in the novice and you definitely need to improvise. Whereas in competent is the one without instruction you're able to do that and none of the steps are missed. So these are the steps which you know that this is how an asepsis is done. And that is definitely something which is assessed at the time of certification course as well. So these are the steps which you have to do it. And once all these steps are done and we go to the next step, that's the gowning. And if you're a novice or if something doesn't know well, you're unable to initiate gown wearing and sterility is not maintained. So in both of these steps, what is most important is the sterility. So you have to wear the gown, taking care that the sterility is maintained throughout the process. Then comes the gloving process. We know it's in 3 processes. First, the one eye, and then first usually the right eye. And then when we're doing it for the left eye, we use the right hand gloves for that. So if the attendee or the assessee is not able to initiate glove wearing, sterility is not maintained, then definitely they come in the form of novice. The next step comes the irrigation of the cornea with a sterile saline and also decontamination of the cornea and the conjunctiva with povidone iodine. So this is how the step looks. And if the step is missed, that is where we say you're just not aware of the step, that you need to first irrigate it with the sterile saline and then only put a drop of povidone iodine solution. So if you've missed the step, obviously that's something we are concerned about. But if you've irrigated it well and removed the mucus and later on then put the povidone iodine and clean appropriately, that's something which is expected of a competent person. So for the technician, when you are preparing the surgical area of the eyelid and the surrounding areas, so it comes in the 3 processes, that is clean the area, then drape the area and also put a speculum. So these are the 3. So we assess them in one go only. And when you're preparing the eyelids and the surrounding areas, it has to be 5 strokes we always talk about. First on the lid, then inferiorly, and then superiorly. If the technician is not able to initiate the surgical preparation without help, that is when we say that you need to be understand this this step. And if you're able to do the surgical site preparation independently, then you come to the competent level of being a technician. So this is how we are saying that the speculum should be put. Again, you see the bud or any, I would say even for the speculum should not, none of the finger should touch the eye, and the speculum can then just be opened. So the next important step for retrieval comes out to be conjunctival removal, and it should be complete 360-degree removal with proper undermining of the conjunctival tissue. If you look at this step very carefully, you know that more than 2 to 3, I would say at least a 4 millimeter of conjunctiva should be easily separated away from the limbus. After removing the conjunctiva from 360 degrees around the limbus, the scraping of sclera is important. And what is most important here would be, it has to be done from the limbus away towards the periphery or towards the fornicial side or the inferior or the superior side. But if this step is missed, it's one of the important, because if you have the residual conjunctiva, the chances of contamination of that tissue is very high. So again, somewhere the asepsis is missed. So it has to be done. So I would not expect any technician to miss this step. So this is how the scraping of sclera is being done. And what is important after that scraping is that you have to discard the forceps and the blade which is used for the conjunctival scraping and pick up a new forceps and a blade when you are going towards the next step of refining. And if you're not refining and going freehand also, it has to be a separate set of instruments. I'm stressing on this step because in the last when we did the assessment last time, this was also one of the steps which was very frequently missed by the technicians. So incision through the sclera, it can be with a trephine, and if you want to go freehand also, that is also permissible. You can make it with a blade. Why we encourage a trephine? You get a very uniform cut and a very good groove through which you can use your blade as well as the scissors to cut it. So this is how it has to be. It has to be moved at least for 2 to 3 times so that it gives you a good groove. So if the incision is again irregular, then it's a matter of concern for us, because now you want at least 2 to 4 millimeters rim of the sclera so that we can go in for lamellar surgery. So if it is regular and it's not penetrating up to the suprachoroidal space, that's also very important. So we do not want that with this trephine, it should go full thickness. And once it's in there, as you see, even if even if you've done it with your trephine, use your blade to enter the to pierce through the sclera. So scissor technique is important. So what I would just suggest, it has to be even cuts and try not to go towards the suprachoroidal space. So whenever your scissor is there, try to just go over here and then do it like this, rather than cutting. The moment you use this, the cut will be irregular. So just at this point, if you're able to do it half and then just proceed further, do this half, proceed further half, that becomes better. We will be showing all this in the video, which is going to follow the steps which are shown here. So again, if you see, even cuts, and this is how the scissor is also supposed to pass. If you look at the third picture, there you can very easily see it's the forceps as well as the scissor moves throughout the eye. So what I always say is, in a CS rim excision, you can also move along with that. So you don't have to be stationary. Nobody's stopping you to. This is one of the most important and sometimes the most difficult step. That's the ciliary body separation from the scleral spur. So if there is distortion of the rim by excessive pulling, then we say we need to master this step more. What is more important is a firm grasp of the sclera and without much distortion of the CS rim. And it has to be a very slow process where you are actually pushing away the iris and the ciliary body from the sclera. The next step is that when you're going to totally separate, it has to be, the choroid has to be pushed away from the CS rim. And you have to really peel it very, very nicely and independently. And there is no piercing happening with no vitreous loss which happens at this point. So if you look at it, these are the steps which are important. You may have to get it to your eye level, may have to bend a little. If you are sitting, we need to stand on that level and then do it. Then only the least amount of stria and the least amount of pull which will happen is going to help you. So when you're going, so again and again, every step, if you look at these pictures, it is very clear that how you're supposed to do it. You have a forceps which is holding your sclera and you're slowly pushing away the choroid and the iris from without pulling the cornea. So see, and you're going to shift your hand swiftly. So when it has happened, another assessment comes out, leakage of vitreous, which may be present, which we would like to avoid. So a competent person is usually able to not get the vitreous out of the cavity. And AC is maintained in most of the steps. So the width of scleral rim is also important when we're doing it. I would say, when you're out or even in the wet lab, it has to have a regular rim which is more than 2 millimeters. Again, placing it in the rim, placing it in the media is also very important. It should not touch at any point. It should not, I would say, fold upon at any point of time. So if anytime you don't have a good grip, it will drop. The moment it drops, it becomes difficult and your sterility is lost. But if it is transferred properly, it maintains a sterility and it is appropriately submerged in the medium. So half of it up, half of it down is also not acceptable. The cells will die. Most of the time when you've transferred it, we all forget that there's one more important step left. You have to check what is the lens status, because you're so relieved once it's transferred into that sometimes you forget to check. This is something which this step should not be missed. It's important to know whether it's a crystalline lens or it is there is no lens present, or it is an IOL which is present in the eye. And after that, you just need to place the cap on that. There is one more step which is like an overall assessment which we do. It is in 2 steps. We call it as manual dexterity. By dexterity, we mean that throughout your hands were not shaking, there was not much collapse, and you were aware of what you were doing. In very normal terms, we say that whatever you were doing, it was not looking like a very shaky procedure. It was not looking that there was, you were confident of the steps and you knew the steps, and all your hand movement and your instrument movement was quite swift. Throughout the procedure, sterility has to be maintained. From the first slide to the end slide, I'm saying the same thing. Please do not compromise on sterility. Make sure there is nothing is touched. There is no point where contamination is happening. This is actually the sheet for assessment of the technicians, and this is how it is going to be. At each step, it will be marked. And you can even use it in the logbooks in your own personal trainings as well. And it is available at the website as well. So these are all which are there. And in the end, you're going to put the date and also remarks if you want. Oh, I found things better. So 1, 2 things, the rest are all steps. But there are 2 steps, again, I say, which is the dexterity. Sometimes understand how the hand movement and your instrument movement is. And the next is sterility, whether it was maintained or not maintained. So these are actually the tool books where you can go ahead and read it. And I wish you all the best when it comes to the assessment. Before I go to the questions, I'm going to take you all to the video, which I would like you all to just have a So any questions? I'm ready to take any questions, and this is actually the brochure for the upcoming EPI conference and from 14th and 15th of September, and where you can register if you want to go in for iBank technician certificate.
If anyone have question, they can either ask directly or they can put it in the chat as well.
So the steps and how it will be done, we will also be taking a very brief session even before we do go in for the certification, so that you can even, it's not something like you want to hide anything what will be asked. It's very, it's there, you can assess, you can understand, and then go in for that, and go in for the certification only when you think that you're prepared, well prepared on that. So practice. And yeah.
And there's a question by Mr. Sushant that which trephine you use.
We use the normal Madhu trephine, which is 16 millimeters, which is available. 14, 16, 18, you can get any. We get the 16 one for our iBank. It's Madhu trephine and it's available. And if there's anything, we can help if you want to purchase for your iBank, where to get it.
There's a question.
Not a very expensive.
There's another question from Pranati ma'am, that what about whole eye enucleation?
In this certification, we are doing a CSWIM. We've not yet made any Reaper or any tool for that. But if that's something, because most of the eye banks have now shifted to CSWIM. But if whole eyeball is something that also needs to be covered, maybe we can cover it. That may be another program we can go in for that. So that's for the Eye Bank Association of India to decide. We'll be happy to take care of that.
Yeah, ma'am. So if anyone have question, please type in fast. Regarding the eye recovery technician certification, like ma'am has already apprised, I will be circulating a registration link soon after the webinar. There will be only some limited slots available for the certification. So there will be only 25 slots. So it will be on the first come, first serve basis. And the fee per participant is rupees 4,000. So please, whoever wants to attend the certification and get assist, please fill in the link fast and make the payment on the UPI provided. And if you have queries and questions, please feel free to put on the EBI webinar group, and we will try our best to answer your queries there.
Thank you, Dr. Manisha. Thank you. Thank you, Rakhi madam.
Thank you. There's a question from Mr. Nilesh that what is the fee of eye recovery technician certification? So the fee for the assessment where you participate is 4,000 rupees. The certification will be only provided if you pass the assessment. But to enter the assessment, you have to pay 4,000 rupees as the fee. So if there are no more questions, then we may end the webinar now. And please, if you have more questions, you can send on The venue is Bhubaneswar this time. That's a typo error from my end. That is Bhubaneswar, where we have the 14th National Conference. So thank you so much. Thank you so much, Dr. Manisha ma'am, for such an interactive and the informative webinar, and hope that many of the technicians will be learning from this and will be applying for the certification program. I look forward to see you all in Bhubaneswar. Thank you.
Thank you for the opportunity, and I'm really hoping a lot of you all to come. Last time we had a very nice interaction with all the technicians, and I assure you, don't get very boggled on how we're going to do it. I'm there, and I normally sit there with the videos, and I will definitely want each of you all to get the certificate, and will train you at even up to the last step, whatever I can, before you enter that. But once you enter, I normally do. I'm not the assessor. I just teach. So I'm not the assessor even for this time. I will be sitting in the room next to that, and whoever has any problem can come back to me at any step, and I would be there to teach. So that's the time I usually just do for teaching, and the assessment is done by more expert technicians and the managers who are there and who do a much better job than I do. So I'll be there, and I'm really looking forward to this. And last time it was a really good participation, and we were all overwhelmed. And this time we thought maybe we'll try to have 2 to 3 stations even for training. And that's something I look up to, so that everybody gets an equal chance. And maybe this becomes like a benchmark from the iBank Association of India, and as Indian iBank, as a step for Indian iBanking, to say that we all do standardized recovery, and we all do it in the same way. So that is the main aim, where in the global front we can do that. So thank you again for this opportunity, and I'm really looking forward to the EPI conference in Bhubaneswar. Thank you.
Thank you. Thank you so much, ma'am, and thank you to all the participants. Thanks a lot.